Welcome, everyone. I'm Gary Luker. I'm the editor of the RSNA journal, Radiology, Imaging Cancer, and I'm also a professor of radiology at the University of Michigan.
And I am Adeline Boettcher. I am the scientific editor at RSNA for Radiology, Imaging Cancer.
So we're here to talk about a recent editorial that we co-authored and presented in Radiology, Imaging Cancer about transitioning to a new normal after COVID-19 with a specific focus on cancer imaging. Like everything else in the world, the global pandemic with COVID-19 and the responses throughout the world to try to mitigate and limit the extent of infection have disrupted cancer imaging, both clinical applications of cancer imaging and research aspects of it. So our goal with this presentation is to inform you about the current state of cancer imaging and projections about what a new normal may look like as we start to transition back to active clinical care and research for cancer imaging. So our objectives are really to understand the changes, challenges, and impacts of COVID-19 and deliver that to the cancer imaging community, those doing clinical work, those doing clinical trials involving cancer imaging and therapy, and those doing more preclinical aspects of imaging research in cancer. We also expect this will be of interest to persons in the oncology community who rely on imaging and imaging research to further patient care and their overall clinical work. So to do this, we're going to focus on a variety of institutions, primarily in the United States, but some from the United Kingdom and China, and address the impact of COVID-19 and response to it on clinical care, imaging, and research in cancer. So background of COVID-19, just to make certain everyone has a similar perspective that we had when we wrote the editorial. By March of 2020, COVID-19 had spread to all 50 states in the United States. And the heat map illustration of the United States shows tremendous geographic diversity in terms of the extent of infections throughout the country. And this geographic diversity will also play into the responses at different institutions enacted to try to limit the scope of infection and the way that different institutions throughout the country will also proceed toward reinitiating cancer imaging in patients and trying to return as close and as soon as possible to conditions that existed before the outbreak. It's important to remember that this outbreak really is less than 6 months old. So the reactions to this are evolving very rapidly, and we expect that there will be ongoing changes beyond what our experts have contributed already. So based on the spread to all 50 states in March, cancer imaging facilities began temporary shutdowns and rescheduling of patients in mid to late March. And after those processes started, we asked leaders in cancer imaging throughout the country, the United Kingdom, and China about the policies they enacted to restrict, limit, or in some cases completely shut down cancer imaging applications, and how that has affected clinical care, clinical research, and preclinical research in cancer imaging. So in general, our respondents emphasized two main priorities: keeping people safe and healthy, and that includes both sides of the equation for imaging and imaging research studies. The patients, because patients with cancer clearly already have a predisposing condition, and the epidemiology of COVID-19 clearly shows the patients with pre-existing conditions that already adversely affect their health are at increased risk of infection and increased risk of severe infection. In addition, many cancer patients undergoing chemotherapy are highly immunocompromised, further increasing their risk. But the equation also includes the persons doing the imaging. So the technologists, the receptionists, everyone involved in that process, or on the research side, everyone involved in performing the experiments, those people also are at risk, and as part of social distancing, needed to be protected as well. And another overwhelming priority for this process was to limit the use of PPE, because that was and continues to be a fairly scarce commodity at hospitals and institutions throughout the country and world. So if PPE can be limited for non-critical activities, then it can be diverted and used for intensive care unit procedures with actively infected patients. So the boxes show a continuum of approaches that people used in terms of how to redirect and change the ongoing management of patients with cancer. These are not absolute, but in general, helped people decide what patients should continue and what patients should be deferred. So urgent studies, ones in which patients are clearly being managed actively, in which imaging will make a clear-cut difference in how those patients are managed, or in cases in which image-guided therapy is important for biopsy, as well as follow-up of high-risk cancers. Those patients, despite the risk, continued as scheduled. Semi-urgent and non-urgent cases clearly overlapped more and needed more of an individualized assessment. But in general, non-urgent cases, which included essentially all lung cancer screening aspects, even some patients with early-stage cancer in terms of initiating therapy, and many elective procedures for follow-up of cancer, all of those type of screening and routine monitoring studies were rescheduled.
So one of the next questions that we asked was about the estimated timeline for resuming postponed appointments and other research studies. So this is a short timeline, which we've already kind of talked about earlier, of COVID-19 within the United States. So in January and February, the number of cases was growing throughout the United States, and by mid-March, all 50 states had at least one case of COVID-19, and this is when these really rapid shutdowns started. So most of the responses that we had were that these rapid shutdowns happened between March 13th and 23rd, and these were shutdowns at imaging facilities as well as research labs as stay-at-home orders were implemented throughout the states. Through April, many of these orders were extended, although some states have started to loosen or lifted their restrictions, and this is happening on a state-by-state basis. In Illinois, just yesterday, April 23rd, it was announced that certain elective surgeries could start back up again. While we're still waiting for the official guidelines, it may be possible that certain imaging appointments could open back up as well. So throughout the months of May, June, and July, there will likely be different iterations of loosening these stay-at-home orders, which will allow imaging facilities and research labs to open back up again. So there's a few considerations that will be important as we move forward. As mentioned earlier, social distancing will still need to be maintained, and this will be important for imaging appointments as well as working in research labs. And on top of this, it's very likely, especially in the clinical aspect, that masks will be worn by all individuals in these different facilities, and this will likely be required in research labs as well. So one of the consequences of the stay-at-home order, too, has been the rise of layoffs around the country, which consequently means that many individuals have also lost their health insurance. So this may also result in appointment delays or just some of these people not coming in for their imaging appointments. So on one end, there may be a surge of patients that had missed their appointments over the last 1 to 2 months, but on the other hand, there may be individuals who don't come into their appointments due to losses of health insurance. So we gathered responses about how specifically institutions will manage their surge in appointments once restrictions are loosened or lifted. In general, the responses were, most institutions already operate equipment at near capacity, so new practices will need to be implemented during this time to really compensate for a potential surge in cases. One of the most common responses to compensate for this would be to extend operating hours into the evenings and during the weekends to open up more appointment slots. Additionally, there may be some imaging protocols that could be shortened to allow for shorter imaging appointment times. One other caveat to this is that due to the outbreak, there will be more intense cleaning protocols that will need to be implemented between appointments, so this will also take time as well. And given the situation, it may take many months to compensate for this lost time of postponed appointments, and institutions will need to continue adjusting plans as we learn more about the course of this outbreak.
So we also addressed how the interruptions, particularly in cancer screening for breast cancer and lung cancer studies, would impact the future of patients who regularly come to medical centers, hospitals, and other care facilities for screening studies. And patient mentality encompasses several different aspects. One, many people believe that the fundamental understanding and belief of people in terms of screening applications would not change. But this will be balanced very strongly by the need to convert everyone, patients and non-patients, if you will, from several weeks of instructions to stay at home, stay away from people, and stay away from hospitals if at all possible. Teaching people that it's okay to start to interact with the world will be an ongoing challenge, and I think, and many of our experts weighed in on this, that could be a major deterrent to people coming back for screening studies. The availability of health insurance is another key aspect of returning to normalcy, not only in screening, but cancer imaging studies. In the United States in particular, health insurance is very closely tied to employment. And as unemployment rates rise, many people may not have ongoing health insurance and may not opt to pay for elective screening procedures. So because of that, many patients may opt out of screening this year. And in terms of health insurance in general, many of the experts noted that patients were actually contacting their facilities in anticipation of a shutdown, wanting to get imaging studies done before the shutdown occurred because of fears of losing health insurance. So a major concern is that patients in remission for their cancer may decide not to reschedule appointments for follow-up and imaging. Again, these patients may regard themselves as relatively healthy and may weigh the risks of coming to a hospital facility and potential risk of infection as greater than recurrence of their cancer. And we list on the slide insurance claims for unemployment in the United States as of April 17th. These numbers actually increased even further. And as more people lose health insurance, it will be more and more difficult for persons to re-enter the normal system of healthcare and cancer imaging.
So for this next question, we shifted gears and asked experts about which restrictions to research activities, whether it's in the lab or clinical, were restricted during this time. So again, most of these shutdowns happened very, very quickly in the middle of March. So there was a lot of quick adaptation to this. And in general, there were three main categories for what to do with these different research projects, which basically fell into shut down and stop, maintain, or continue and start. So starting with shutting down the project, so institutions were told to shut down non-critical research activities. So for cancer imaging studies, this may include preliminary studies that would not directly affect patient outcome or treatment courses. And then for laboratory research, this may include smaller research studies or experiments that could easily be started back up or were not expensive. And in some institutions, animal breeding was stopped during this time, and in some cases, mouse lines were euthanized to ease maintenance during the shutdown. There were also some projects that were maintained. If there were cancer imaging studies in which a lot of time and money had been spent or invested, it would be costly or time-consuming to do again, these were maintained. Additionally, in terms of the laboratory research, irreplaceable animal lines were also maintained. And then lastly, there were some projects that were allowed to continue or be started during this time period. So cancer imaging studies in which imaging would impact a course of treatment or affect patient health, these studies were maintained. And then additionally, during this time, many COVID-19 projects were initiated, and these were given institutional review board priority for application review and approval. So I'm sure during the next couple of months we'll see some different priorities by institutional review boards.
So then we also addressed, as our final question, the potential short and long-term impacts on cancer imaging research. And as you can see, these are broken down really by time frames, and the more than 12-month time frame is probably being very generous, as effects may extend for several years. During the initial periods, many people saw this as an opportunity to finish manuscripts, finish old grant proposals, and initiate new ones. I'm certain that foundations and federal agencies like NIH will receive many more applications this summer than they might have otherwise. People also took this as an opportunity to start retrospective studies, and both students and faculty began taking new online courses, computer programming, bioinformatics, image analysis methods. During the time period as patients start to return to the clinic and operations start to return to ramping up periods as opposed to ramping down, considerations will need to be extended to students, medical students who are looking for residencies, PhD students who are needing to graduate and need research productivity to do so, and undergraduates seeking to enter medical school or other professional schools. Many prospective studies will have lost data that in many cases will be irretrievable. Longitudinal studies using imaging to track response to therapy in patients. Many time points have been lost, and many patients may not decide to return to those studies. And the transition back to work in a research setting will require social distancing applications. That may be very challenging for clinical studies where patient interaction is critical to the actual study design itself. And even in a laboratory setting, that will require reconfiguring work schedules and working to maintain social distancing while still trying to be productive. And then in the longer term, faculty will need essentially time-off considerations for getting tenure. Many institutions have frozen hiring for variable periods of time, extending into 2021 at least. So faculty positions will become increasingly harder to get, and many persons who might have pursued academic careers may not have that opportunity. Funding organizations may prioritize infectious disease and pandemic response aspects, which will directly impact the amount of money available for cancer imaging studies. And the overall economic crisis likely will reduce the amount of external funding that's available to support research overall, including cancer imaging studies. Many radiology departments who normally would have had internal pilot grant funding to support research, those opportunities may go away as most institutions now face severe deficits in their budgets. So in conclusion, we've tried to highlight some of the challenges that remain for the current status of cancer imaging and how to transition back from stay-at-home orders to ramping up procedures for cancer imaging and cancer imaging research. There are huge uncertainties about patients and rescheduling their imaging studies, both in terms of the patient willingness to do so, the capacity of institutions to handle those appointments, and ramifications of losing insurance. And finally, the economic impact from the pandemic is a serious threat to current and future imaging research in cancer. Thank you for your time.